Assalamu alaikum. Welcome everyone for the session today. Dr. Shabbir Jamani is here and he will be conducting the session. Dr. Anum, I will request you to please start your screen sharing. I think a few more people will be starting to join in again. Thank you.
Thank you, Komal. Assalamu alaikum, sir. Good to see you with us. I hope my voice is clear to everybody.
Yes, it is very clear. Please carry on.
Yes, and my screen is visible.
Your skin is not visible, I think.
Okay. So today my topic is, first of all, I will give my introduction. I am Dr. Anum Mughal, Senior Registrar from Department of Anesthesiology, Surgical ICU and Pain Management. Today my topic of presentation or teaching is about adrenocortical disease and its implication in anesthesia. So the highlights of the topic is as follows. First of all, we will go through the introduction, then some anatomy, which is relevant to us about the adrenal glands, physiology of the hormones secreted by these glands, diseases which are associated with adrenal cortex only, its medical management, finally its anesthetic concerns, and some associated emergencies with the disease. So why adrenal glands are so important?
Excuse me, Dr. Anum.
Sorry to interrupt. There is no screen sharing.
We can't see your screen, Dr. Anum.
Okay, I think now you can see it.
The screen is visible now.
Okay. Thank you. Okay, thank you for telling me. Okay, so this is our topic, anesthesia and adrenocortical disease. And our objectives are as follows, which we will learn today in the presentation, introduction and anatomy. So finally, going through the introduction, why adrenal gland holds a very important place in a human body. So what actually happens that the body's internal environment, it's a complex process of interconnected pathways, and the major links of these pathways is through adrenal gland. The gland is, however, small, but it secretes major hormones, and therefore major medical conditions are also associated with it. So these conditions and understanding of these conditions, this knowledge is very important, because someday in life, we are going to have a patient with adrenal disease who will present to us either for adrenal gland surgery or with some non-adrenal gland surgery, but having some adrenal gland disease. Okay. This is a pictorial that is showing you the anatomy of adrenal glands that reside on the kidneys, on the superior pole of the kidneys. It has two major divisions, which is adrenal cortex and adrenal medulla. They are located behind the abdominal cavity and peritoneum in the retroperitoneal space.
I apologize to interrupt. Actually, I think you just make the screen like what is the button is, so that the screen will be enlarged. Your slides are looking small. So if you will just, yes, slideshow. I think it is better. Yes, thank you. Thank you. Sorry to interrupt.
Okay. Okay, so these are located behind the abdominal cavity and in the peritoneum, in retroperitoneal space, and on the superior pole of each kidney. And they are surrounded by renal fascia and adipose tissue and are obedient factories that produce essential hormone for the body. So this is where we will find the adrenal glands up above the kidneys. The blood supply, arterial supply of adrenal gland, it is derived from three major adrenal arteries, the superior, middle, and inferior. All of these arteries are further a branch of different arteries. The superior suprarenal arteries is derived from inferior phrenic artery. The middle suprarenal is from aorta, and inferior suprarenal artery is from the renal artery itself. So this is how where you can see the inferior phrenic artery, which I am pointing out, it comes from the main suprarenal arteries. The middle suprarenal artery is from the aorta, and the inferior suprarenal artery is from the renal artery itself. Now talking about the venous drainage. So the suprarenal veins, they drain into two different veins. The right one drains into inferior vena cava, and the left one drains into left inferior phrenic or left renal. So the picture is presenting you the venous drainage as well. This is the right suprarenal vein that is going into the inferior vena cava. And this is the left suprarenal vein that is going into the left suprarenal vein or into the renal vein directly. Nerve supply is also very important as it is an organ of hormone production. So it has rich nerve supply as well. It usually gets supply from celiac plexus and thoracic splanchnic nerves that supply the chromaffin cells. Now the question arises, what is chromaffin cells and why do here we use these words chromaffin cells? Please have a look. The supplies from T8 to T1, the ventral roots, they take the shape, they take the name of thoracic splanchnic nerves and then go to the adrenal gland, where they are involved in the secretion of epinephrine and norepinephrine and other hormones. These adrenal medullary cells are called chromaffin cells because they ultimately secrete their medullary hormones. So they are functionally divided into two different distinct zones. The inner part is medulla, that is involved in the secretion and production of amine hormones, which are involved in sympathetic activation system, the adrenaline and noradrenaline. Because the medulla is essentially a chromaffin ganglion and it receives its post-ganglionic cells. Its post-ganglionic cells have become secretory. That is why it is named as chromaffin cells. The other name is also pheochromocytes. However, the outer part of adrenal gland, as we all know, is cortex. Because my topic is about adrenocortical disease, so we will be only focusing on adrenal gland, on adrenal cortex of adrenal gland, not on the medulla. Let's discuss about adrenal cortex. Three main types of hormones are secreted by this gland: the mineralocorticoids, glucocorticoids, and androgen. And different regions secrete different hormones. You can see from this picture, the outermost part is the zona glomerulosa. The middle one is zona fasciculata, and the inner one is reticularis. And the innermost is medulla, which of course secrete epinephrine, but we will not be discussing it. The glomerulosa is involved in secretion of mineralocorticoid, fasciculata is involved for secretion of glucocorticoids, and reticularis for androgens. The physiology of these hormones are as follows, that all the adrenocortical hormones, they are produced from a common precursor, that is cholesterol. This cholesterol is either received from the circulation or it is endogenously synthesized in the gland. They are also termed as C21 hormones. Why? Because they have 21 carbon atoms. Whereas the sex hormones, they are called C19 steroids because they have 19 carbon atoms. Now going into detail of zona glomerulosa, the region of the adrenal cortex, this region produces aldosterone. We all know that aldosterone is a mineralocorticoid. Its release is actually the end point of renin-angiotensin and aldosterone system, which takes into renal system in its activity. This system plays important role in regulation of blood volume and systemic vascular resistance, through which altogether cardiac output and blood pressure is maintained. Learning of function of each of these hormones is very important to us because this is how ultimately we will learn the anesthesia concern. So make your concept clear about the role of these hormones in our body. The main action of aldosterone is to retain sodium in the kidneys and in exchange of potassium, of course, because retaining one positive ion, the body has to secrete another positive ion. And this in turn causes fluid retention because sodium also drives water with it. Now the aldosterone can also be released. It actually releases by renin-angiotensin system and also by ACTH. So basically aldosterone is under control of two systems, the ACTH, which is secreted by anterior pituitary, and renin-angiotensin system, which is secreted by the kidneys itself. Whenever there is any physiological stress or trauma, or the body has hyperkalemia or there is hyponatremia. So in these conditions, aldosterone is automatically secreted in excess quantities. This is the cycle that shows how aldosterone reaches in our body. The kidney secretes renin, which by the action of angiotensin 1 converts into angiotensin 2 by the action of ACE enzymes. And this is how angiotensin then further augments the function of aldosterone. what happens? The aldosterone angiotensin causes ACTH secretion, sympathetic activation, and vasoconstriction, while aldosterone causes sodium and chloride reabsorption in exchange for potassium and water reabsorption. All these three mechanisms leads to expansion of extracellular fluid volume, and that leads to hypertension. Other than that, there is arterial stiffness, hypertension, and cardiac remodeling. Why? Because aldosterone is also accompanied with angiotensin, and angiotensin ultimately leads to vasoconstriction and sympathetic activation. So together, these hormones causes hypertension, modeling, and arterial stiffness. And as you can see in this picture, that aldosterone is also under the control of renin and ACTH. The next zone is zona fasciculata, that is involved in the secretion of cortisol. Its main action is gluconeogenesis. So whenever there is a stress or fighting or stress or fasting, or in any condition surgical where the patient is not able to take orally, then this hormone comes, makes its role and start producing glucose by gluconeogenesis. That is why it is also termed as glucocorticoid. However, it also has some mineralocorticoid activity. Its major function is in response to stress and suppressing the immune system. It also maintains level of glucose in the body, as I told you, by stimulating gluconeogenesis. It also regulates protein, carbs, and fats. And it is released under the control of hypothalamic pituitary axis. Everything is under control in our body. Whatever adrenal gland is secreting the cortisol or aldosterone, it comes by some regulation. So cortisol also has some diurnal variation with a peak at 8 a.m. So please have a look on this negative feedback and positive feedback system that shows that the hypothalamus secretes cortisol releasing hormone, and then the cortisol releasing hormone secretes ACTH from anterior pituitary, and this ACTH is involved in secretion of cortisol and ultimately the metabolic effects. And finally, when there is lots of cortisol in the body, it itself gives a negative feedback to anterior pituitary and to hypothalamus to stop the secretion of CRH and ACTH. So any feedback mechanism which is disrupted, it ultimately results in huge clinical manifestations. The last one is zona reticularis, this region of adrenal cortex. Why it is named so? Because it has some reticular appearance, and it is involved in the production of dihydroepiandrosterone and androstenedione, which are actually weak androgenic sex hormones, and they are involved in protein anabolism and growth. So this is the table that is showing you the major actions of glucocorticoid and mineralocorticoid, which is very nicely summarized. Please focus on mineralocorticoids. It is involved in key functions only, which is sodium reabsorption and ultimately secretion of potassium and hydrogen. So you can easily interpret in your mind that if there is excess secretion of mineralocorticoid, then of course there will be excess of sodium and water in the body, and there will be hypokalemia and alkalosis because it ultimately leads to potassium and hydrogen secretion. So these are what the clinical manifestation which you will find in your patients if they present with such diseases. Now coming to glucocorticoid. Glucocorticoid is very vast hormone. Its actions are involved through liver, cardiovascular, kidney, and immune system. It is involved in protein catabolism, breakdown of protein. So actually it is a catabolic hormone, while the androgen, it is an anabolic hormone, which are weak sex hormones. Okay, other than that, in the liver, it is involved in gluconeogenesis. So it breaks down protein and ultimately makes glucose available for the body in conditions of stress or fight or fasting or any states like that. In cardiovascular system, it is involved in maintenance of responsiveness of catecholamines. That is the reason we use glucocorticoids in septic patient, and we have got so many researches on it. It also has some weak mineralocorticoid activity. So it is also involved in sodium reabsorption and potassium and hydrogen secretion. Furthermore, it is also involved in immunosuppression and slowed healing. So this is what the cellular actions of glucocorticoid at cellular level. Okay, regulation, which I have already told in detail, that it is the negative, it is regulated by a negative feedback system. In a healthy individual, cortisol is secreted from adrenal in diurnal variation, peaks at 8 a.m. and then in the evening. And this cortisol comes by the secretion of ACTH from anterior pituitary and from CRH from from hypothalamus. So at any point, whenever there is excess of cortisol in the body, then it is not only the adrenal glands which are at which may be diseased. The disease can be at the pituitary level also, and the disease can be at hypothalamic level also, which we need to discuss, which we need to dig out from the patient by lab investigations. Okay, now please have a look on some of the common disorders of adrenocortical function. So there are two major diseases which correspond with the hypersecretion. Either there will be hypersecretion of cortisol or hypersecretion of aldosterone. The hypersecretion of aldosterone is called as Crohn's disease, while the hypersecretion of cortisol is called as Cushing disease, basically. Okay? Okay, they have also further divided it into primary hyperaldosteronism and secondary hyperaldosteronism, which I will be telling you. They are about the different conditions in which aldosterone secretion is raised in the body. Okay, so as you have, I have very briefly and in detail told you about the function of aldosterone, so you can easily find out that whenever the patient is suffering from any condition of hyperaldosteronism, what clinical manifestation it will give you? It will be hypertension, hypokalemia, and alkalosis. Why? Because the reason is in front of you. Patients suffer from hypertension because of excessive resorption of sodium and water in exchange for potassium, that ultimately leads to hypokalemia, and in exchange of hydrogen ion, that ultimately leads to alkalosis. Okay. So whether it be primary hyperaldosteronism or secondary, the clinical features will be same, but the cause of hyperaldosteronism will be different. Okay, now coming towards Cushing. So you can see either there will be excess secretion of renin from the kidney, either there will be excess secretion of cortisol from adrenal gland, or either there will be excess secretion of ACTH from anterior pituitary. Whatever be the reason, it will ultimately lead to higher levels of glucocorticoid hormones in the body. And whatever the function we read, these will be visible in the patient in as such as altered appearance, bruising, muscle wasting, hypertension, diabetes, and hypokalemia. Okay. Okay, the last one is Addison disease. Addison disease is opposite to these conditions. Addison disease is actually hypofunctioning of the adrenal gland. So these will be our three main topics. We will be discussing the hyperfunctioning and hypofunctioning. In Addison disease, there is hyposecretion of cortisol and aldosterone all together. It is not a separate disease of cortisol or aldosterone. It comes all together. And what happens when the cortisol is decreased in the body? The patient may have hypoglycemic attacks. He will have hyponatremia, exactly opposite to its function. The patient may have hyperkalemia, raised urea, metabolic acidosis. And if there is decreased aldosterone, it can present to you as acute condition or as a chronic state. Whenever it presents to you as an acute condition, so this is a medical emergency. The patient may have abdominal pain, vomiting, dehydration, and hypotension. And if it is a chronic state, then the patient will be presenting with chronic fatigue, pigmentation, anorexia, weight loss, or postural hypotension. So usually in anesthesia practice, we do not receive patient of Addison disease in chronic state. This is totally a medical condition, and they are usually treated under medical ward. However, we do receive patient with acute adrenal crisis, which is acute adrenal insufficiency, which is also called acute adrenal insufficiency as well. Now going in some details of Crohn's disease, as I already show you that it's primary or secondary. Now, what are the causes? These are the causes. Whenever there is primary hyperaldosteronism, either there will be excessive secretion of aldosterone from adrenal adenoma that can develop spontaneously or whatever be the genetic mutation. And this is when the patient comes to you for the surgery. And this is where your brain should start storming that what concerns you will be having in the patient who is presenting with primary hyperaldosteronism, presenting for the surgery of adrenal glands. The other one is other reason is bilateral adrenal hyperplasia. Usually these patients are not undergone surgery. They are usually medical treated, and rarely there can be adrenal carcinoma as well. Okay, in reasons where there is a secondarily high concentration of aldosterone, it is usually due to congestive cardiac failure or liver cirrhosis. So in these conditions, the renin-angiotensin aldosterone system is already activated in the body. So in these patients, you can also receive hypertension and hypokalemia, hypernatremia, all such clinical features. Okay, these are some details about the clinical features which I have already told you as well. So overproduction of aldosterone, you can now easily do it by yourself. The patient can present to you with hypertension. Because of this hypertension, they can have headaches also because of raised ICP. They can have muscle cramps also. Why? Because of the low potassium. Because of course, potassium is involved in maintenance of resting membrane potential. Ultimately, due to loss of hydrogen ion, they will be presenting with metabolic alkalosis. And due to this metabolic alkalosis, less of the calcium will be available to the tissues, which can cause the symptoms of hypocalcemia. And because of this hypocalcemia, the patient can present with paresthesia, tetany, carpopedal spasm, and muscle cramps. So, you know, the features are very vague. One has to one has to think a lot, should have a critical thinking to get to the diagnosis. Now, these are some different tests which are usually run in these patients, and we should, I think, just knowing about the name is enough for an anesthetist, because we are not going to run these tests. They already have it in their pre-op clinic by their primary physicians, not by us. So what is actually these tests? Test confirmation in many cases can be made by measuring plasma or urinary aldosterone and renin levels and ratio of these two. Aldosterone to renin ratio, it helps to eliminate other factors such as time of delay or sol loading. A ratio of greater than 4 is consistent with Cohen's syndrome. Means the patient is made to measure aldosterone and renin separately, and then their ratio is compared. If the ratio comes greater than 400, then it is consistent with Cohen's syndrome, hyperaldosteronism. Then the problem is with secretion of aldosterone. Aldosterone is secreted more than renin. Other than that, there is MRI scan of adrenals, bilateral adrenal vein catheterization, or scintigraphy, labeled precursor of aldosterone, to assist in differentiating between an adenoma and hyperplasia. Because as I already told you, in both of these conditions, whether it is an adenoma or hyperplasia, aldosterone is secreted. But surgical procedure is always done in patients who are having adrenal adenoma. Okay. Okay, so what is the treatment? What about those patients who are having bilateral hyperplasia? Usually these patients are treated with spironolactone and ACE inhibitors. So patient presenting to you in pre-op clinic with any of the adrenal abnormality, they will be on spironolactone and ACE inhibitor. Now, just talking about the anesthetic concern, which is very important to us, as now all the anesthetic concerns will be driven by the function which is performed by aldosterone. Because there is excess of aldosterone, so excess of potassium will be depleted, excess of sodium will be retained, the patient will be hypertensive to you, there will be hyperkalemia and metabolic alkalosis, sorry. So what you have to do, you just have to make them optimize as much as you can. Okay. What other thing happens? Action of non-depolarizing neuromuscular blocking agents are altered because of low serum potassium. Low serum potassium, baroreceptor tone is also suppressed. So, you know, you have to avoid hypovolemia, or you have to treat it aggressively, because they have lost their vasomotor tone. Spironolactone are usually given in doses of 400 mg. That also moderates, it also had electrolyte and metabolic effects, you know, so it brings normalization of metabolic alkalosis as well. Other than that, because of hypertension, the anesthetist should dig out features of end organ damage as well, which are left ventricular hypertrophy or stroke, or, you know, renal nephropathy or eye diseases, such like that. Okay, patient usually present with unilateral bilateral adrenalectomy. May be performed to treat Cohen's syndrome depending on the pathology. And whenever, even if the adrenal gland surgery is going on, a little bit manipulation on adrenal gland during the tumor removal, it also causes intense cardiovascular instability because of the secretion of catecholamines from the medulla as well. However, it is not as severe as pheochromocytoma. Okay, once the patient has undergone surgery and they have undergone unilateral or bilateral adrenalectomy, then ultimately their cortisol levels will be diminished post-operatively. So replacement of steroids and mineralocorticoid activity is therefore required in all those patients who are undergoing bilateral adrenalectomy. So this is a very important point that you all should be having in your mind. If we are doing such surgeries on adrenal gland. Okay, what are the doses? Hydrocortisone is given IV from the time of operation until oral medication can be initiated, whereupon oral fluticasone and hydrocortisone are given thereafter whenever the patient gets discharged to ward. The other condition is Cushing syndrome or Cushing disease. This is very well known to us. This is the second topic which we are discussing. These may be secreted by adrenal cortex or exogenously administered. Usually you receive in your pre-op clinics the patients who are on exogenous steroids because of some medical conditions such as SLE or osteoarthritis or any immunosuppressive diseases, autoimmune diseases, or either you will get a patient who have some disease in adrenal cortex itself. So excessive secretion of cortisol is most commonly secondary to ACTH secretion from an anterior pituitary adenoma. We all know, of course, from MBBS that this is called as Cushing disease. Whenever there is excess secretion of cortisol secondary to some pituitary disease, it is called as Cushing disease. So this ultimately leads to bilateral adrenal hyperplasia. In 20 to 30% of the patient, the cause is in the adrenal gland. There can be adrenal adenoma, just like we read in hyperaldosteronism. More rarely, the Cushing syndrome is secondary to ectopic ACTH, which can be secondary to carcinoma of lungs. So, you know, here there are multiple reasons where you can get excess secretion of cortisol. Either it can be due to anterior pituitary adenoma, where it is labeled as Cushing disease. Either there can be adrenal adenoma in the adrenal cortex itself, or there can be ectopic ACTH from some kind of carcinoma of the lung. Clinical features, we already know it is because of cortisol, and because of cortisol, there is excess of the patient goes into central obesity with buffalo hum. The skin gets thinned out. There are bruises and purple stria on the abdomen and thighs. The muscles are wasted. Patients are prone to osteoporosis. They have hypertension. Why? Because cortisol is also involved in retention of sodium. So it is also involved in mineralocorticoid activities. So the patient has hypertension and left ventricular hypertrophy. They have impaired glucose tolerance. Why? Because cortisol is involved in gluconeogenesis. So they have type 2 diabetes. And hypokalemia, of course, as I have already told, because of mineralocorticoid effect. So this is a mnemonic which you can easily learn by its name. Cushing, the patient can present with central obesity, urinary free cortisol, stria, hypercortisolism, and neoplasms or glucose intolerance, growth retardation, hypertension, hyperglycemia. So, you know, this is the mnemonic by which you can easily put it on your patient when he is presenting to you in pre-op clinics. So this is a picture. Very common picture. Establishing the cause. Once again, you just need to have it superficially. You don't need to go into the detail because we don't need to establish the cause. High dose of dexamethasone suppression test. It is given when there is given in order to distinguish if the circulating cortisol is because of adrenal gland or Cushing or ectopic ACTH secretion. Okay. And then serum ACTH concentration are checked. These ACTH concentrations are raised in Addison disease in which there is hypocortisolism. Okay, because cortisol is not producing from adrenal glands, so ACTH concentrations are raised in such patients. Ectopic production of ACTH and Nelson syndrome, and low concentrations are seen in Cushing syndrome. Why? Because there is already excessive secretion of cortisol, and by negative feedback, it suppresses the ACTH secretion from anterior pituitary. MRI of the pituitary fossa, CT MRI of the adrenal glands, of course, to establish the surgical causes. Inferior petrosal venous sampling after CRH stimulation. Excuse me. Now, what are the treatment options for these patients? Of course, whenever one can get the surgical cause, either the cause is from the hypothalamus, sorry, either the cause is from anterior pituitary or the cause is somewhere in the adrenal gland.
Um,
Patients are
comment?
subject to
Dr.
surgery.
Anum,
Okay,
are you there?
carcinoma,
This
surgical
meeting-
removal. Okay, hello.
Dr.
Can you
Anum,
hear
I
me?
think there
Because I
was
just
some
had some
interruption in the connection. Can you please repeat that
Yeah.
again?
Okay, okay. Now can you hear me clearly?
Yes, now.
Okay. Okay, so I was just discussing about the treatment, After establishing the cause, one can know if the patient will end up into surgery or it can be treated medically. Okay. In case there is an adenoma in the pituitary fossa or there is an adenoma in the adrenal gland, then such patients are subject to surgery. Other than that, there is a new drug which is metirapone inhibitor of cortisol synthesis. It may be useful in cases where surgery is not amenable. Now discussing about the anesthetic concerns, many of these patients have poorly controlled hypertension. And because of this hypertension, they ultimately end up into end organ damage. So these these organs should be, optimized preoperatively. ECG abnormalities may suggest ischemic heart disease, but these may be related to Cushing disease itself and may revert to normal after curative surgery. Further problems are encountered because of patients' obesity, because obesity is itself a metabolic syndrome. These patients can present with sleep apnea, sedation, over-sedation, resedation, and tracheal collapse. And all these things you can get in such patients as well because of their obesity. And this is obesity which they have acquired because of circulating level of glucocorticoid. They have impaired glucose tolerance. So of course, optimization of their sugar levels and diabetes is also very important. They are also at risk of GERD, gastroesophageal reflux diseases. So they often require pre-op acid suppression. Extra care should be taken with positioning because they have very fragile skin. Their bones are already osteoporotic. The third and the last disease, which is Addison, which I already told you, it is about the hyposecretion of cortisolism. Because cortisol is already has some mineralocorticoid activity and glucocorticoid activity. So such patients who present with Addison disease, they have both clinical manifestation of deficient glucocorticoids and deficient mineralocorticoid activity. So adrenal insufficiency, it is usually divided into primary, secondary, and tertiary causes. Primary adrenal insufficiency, it occurs when the pathology affects the gland itself. Secondary insufficiency results when there is decreased ACTH from the pituitary gland, and tertiary adrenal insufficiency results from a decreased level of CRH that is released from the hypothalamus. So once again, they have divided in order to make it easy for the readers. Now, what are the clinical features? Of course, when there is a deficiency of hormones which maintains the blood volume, which retains sodium, or which is ultimately involved in metabolism of glucose. So when these hormones are weak, are less in the body, then what happens? The patient suffers from chronic fatigue and lethargy, low mood, there is loss of appetite and unintentional weight loss. Patient has hypotension, increased thirst, craving for salty foods, and hypoglycemia. Because they are losing their sodium, they are not able to undergo gluconeogenesis. So starving or any kind of hypotension, they are already prone to it. The lack of cortisol fails to feed back to the pituitary, and so there is continuous production of ACTH. So what happens? You can get high levels of circulating ACTH if the primary cause, if there is primary hypoaldosteronism, if the cause is in adrenal gland. Consequently, the ACTH levels are high, and when the ACTH levels are high, MSH, which is melanocyte stimulating hormone, this is also released in conjunction with it, and that leads to characteristic pigmentation of skin and buccal mucosa, which is seen in these patients. So once again, these patients are medical patients, and they present to you if there is some surgical cause, which is in the pituitary gland or in the adrenal gland. So this is how the patients look to you. The skin is usually pigmented. There is disturbance in distribution of body hair. The patient has weakness. There is weight loss, thin lean patient, and postural hypotension. These are few tests which are run to differentiate the causes: short synectin test and adrenal antibodies and radiological imaging. So of course, because they are unable to produce mineralocorticoid or glucocorticoid hormones, so how they are treated? They are treated by giving the replacement of these hormones, which are hydrocortisone and fludrocortisone. So once again, as I told you, these are medical patients. You may have these patients when they are in adrenal crisis in your ICU. Some of the anesthetic concerns, you can also have these patients for non-adrenal surgeries as well, like lab chole or any other thing. These patients should be given all their routine medication on the morning of surgery. Now, this is very important because they are already on hydrocortisone and fludrocortisone. So these should be given. Their serum potassium, glucose, sodium, this should be checked preoperatively. They should be optimized. Now, these are some regimes which are divided for minor, intermediate, and major surgery, that how much hydrocortisone should be replaced in them. If the patient is undergoing minor surgery, such as any superficial surgery, eye surgeries, or superficial incision and drainage, which is of course not the emergency surgery, in these surgeries, the above regime is enough, which is 25 mg hydrocortisone. For intermediate surgeries like hysterectomies or lap choles, they can have hydrocortisone 25 mg given over first 24 hours. Means and then for major surgeries, 200 mg of hydrocortisone each 24 hours until the patient can be restarted on maintenance therapy. And it is also advisable to consult and share the patient care with an endocrinologist. Now, some of the highlights of adrenal disease and ICU. 2-3 conditions which you will be encountering in your ICU, which can be Addisonian crisis or Sheehan syndrome. What is Addisonian crisis? As adrenal crisis or acute adrenal insufficiency, it is an endocrinological emergency with high mortality rate secondary to physiological derangements from an acute deficiency of adrenal hormone, the cortisol, that requires immediate recognition and treatment to avoid death. And what is the treatment? IV hydrocortisone. An initial dose of 200 mg is followed by 100 mg every 6 hours until oral supplements can be taken. Other than that, fluid resuscitation is required and dextrose may be necessary to treat hypoglycemia. So whatever their presentation is, these has to be treated in your ICU. Invasive monitoring has to be considered in these patients, because these patients are already hypoglycemic, they are hyponatremic, they are hypovolemic. So all these things should be considered and resuscitated in the ICU or HDU systems. Secondary hypocortisolism, pituitary tumor, or Sheehan syndrome. This is the situation which is usually encountered in obstetric patients. What happens during pregnancy? The blood volume is increased and the anterior pituitary is somehow increases in size, and its blood supply is also increased. Whenever there is any condition that leads to PPH or APH or hypovolemia, any condition in where there is blood loss in an in the obstetric patient, it ultimately leads to necrosis of the pituitary gland. So the patient present to you with these with delayed lactation, inability to lactate, hypotension, low mood, and hypoglycemia. So this should also raise suspicion in your mind that there is something wrong going on with some endocrinology of this patient. Okay, so this is Sheehan syndrome is actually secondary to hemorrhage in an obstetric patient that leads to necrosis of the pituitary gland. Okay, now this is the chart that is showing you the treatment of Addisonian crisis in an ICU. What we have to do, take large bore venous cannula for rapid fluid infusions, A-line for continuous invasive blood pressure monitoring, measure blood gases and acid-base status, central venous catheter to estimate right arterial filling pressure. And of course, for that case, we need that the myocardium is all right. It doesn't have any right or left heart pathology. And also to guide you for inotropic and vasopressor support. Cardiovascular function monitoring, that includes cardiac output and transesophageal echocardiography. Catheterization to monitor renal function and fluid balance. So you see, the above 5 points are actually indicating you that how much fluid balance is needed in Addisonian in patient who present to you with Addisonian crisis. Okay, treat the extravascular dehydration and hyponatremia with normal saline. Correct hypernatremia very slowly. Correct hypovolemia with plasma expander. Hypoglycemia with glucose infusions. Insulin infusion may be needed to lower serum potassium concentration to make it shift intracellularly. Hydrocortisone 200 mg bolus or any equivalent dose of other glucocorticoid other than hydrocortisone, and then 100 mg in 24 hours. Fludrocortisone, of course, because we also need some mineralocorticoid activity. Hydrocortisone do not have that much mineralocorticoid activity, so fludrocortisone should also be given. That is 0.1 mg daily. And norepinephrine infusion may be needed to counteract hypotension until unless the hydrocortisone and fludrocortisone takes on their full action in the body. So you see, this is the emergency. Okay, now this is Sheehan syndrome, which I
D-
Dr. Anam, Dr. Anam, are
Dr.
you there?
Anam, we cannot hear you properly or correctly. Hello. Hello.
I think sir, there's some problem with the connection. I'll just check with her.
told you. So I'll hello.
Yes,
reconnect
Dr.
हो गया.
Anam.
हो गया reconnect. सही. Okay. Okay, now you can see my screen. Can you all see my screen?
Yes, please go ahead. Go ahead, Dr. Anam. We can see your screen. Hello. Hello.
I think she's having some problem with the connections. I'll just ask her to reconnect again. Sorry for the interruption. Please bear with us. Dr. Anam is reconnecting again. Hello, Dr. Anam, are you there?
Yes, I'm here. आपको आवाज आ रही है?
जी जी.
Yes,
Dr.
Dr.
Anam,
Anam.
there's a sorry, sir. Dr. Anam, there's a request if you can repeat the Sheehan syndrome part because the voice is very much interrupted in that part.
Acha, please tell me if I have to repeat this slide only or Sheehan syndrome as well.
I think from the Sheehan syndrome.
Okay. So Sheehan syndrome, as I already told, that this is an obstetric condition. So what happens that during pregnancy, the pituitary gland, it enlarges in size, and ultimately its blood supply also comes from low pressure portal vein. So it also has a lot of blood supply as well. And any condition in which the pregnant patient has hemorrhage, undergoes hemorrhage, either it is APH or PPH or any other trauma. I'm actually having some problem in my internet signals. That is why the voice is distorted.
We can
I
hear
hope
you,
it
Dr.
continues.
Okay,
Thank
yes,
you.
we can hear you.
Okay. So ultimately, what happens when there is a hemorrhage, such an hemorrhage that causes the state of shock, hypovolemic shock. So the pituitary gland, it undergoes necrosis, and when the pituitary gland undergoes necrosis, ultimately whatever the hormones which are secreted by this gland, it goes into decline. So the patient, the female patient, experience amenorrhea and failure to lactate, and ultimately she also has signs of hypothyroidism and hypocortisolism, like Addisonian disease, but it also develop gradually. Okay. So, and the women experience gradual onset of the symptoms which are secondary to adrenal insufficiency. So this is the one more condition which you can, you will, you can have in your ICUs. Acha, the third condition is relative adrenal insufficiency in patients, in critically ill patients. We all know that in those patients which are longest standing in our ICU because of some changes in their nutrition and because of their septic load and their surgical causes, there is some, and because of the continuous stress
Excuse me,
in
Dr.
their
Anam.
body which is
Would you
going
please
on.
sum up? Excuse me, Dr. Anam. Would you please sum up? Then we won't have any time for questions,
Yes, sir. This is, I only 2-3 more slides are remaining now.
Things that there are only 10
And
minutes left,
you
and
can see for the
we
question
have to
answers
conduct the
as well.
questions as well,
Yes, sir.
Thank you.
So, okay, sir. These patients should be kept on steroid replacement as well. Okay, now this is just a glimpse of recent guidelines which I'm going to share with you. You can have these patients anesthesia for patients with adrenal gland disease. So, as I have already mentioned, that you can have these patients with for the surgery. This is just a repetition, but this is from the recent guidelines. What they are saying, that typical signs of primary hyperaldosteronism, which comprises of hypertension, hyperglycemia, and alkalosis. So this should be treated preoperatively with spironolactone. So this is highly recommended. Spironolactone is highly recommended in patients who are presenting to you with primary hyperaldosteronism. The second is with Cushing syndrome. In these patients, they are at risk of infection and thromboembolism. So concomitant further disorders should be taken into mind. And other than that, those patients who are with suspected adrenocortical insufficiency, they should be supplemented with hydrocortisone. It is mandatory. Okay. The other recent guideline which I found useful is anesthetic consideration on adrenal gland surgery. So this is a very good slide. Maybe we are short of time, so I'll share you the presentation in which they have very nicely divided the pre-op, intra-op, and post-op period. What we need, the cortisol inhibition in pre-op period, hypertension, hypoglycemia. In intra-op period, there should be a general endotracheal anesthesia plan with epidural, careful positioning, pre-medication, aspiration of gastric wrist should be taken, airway management, careful pre-oxygenation, invasive monitoring. And in post-op period, there should be acute pain therapy. The biochemistry test should be run for close monitoring of sugars, electrolytes, and cortisol. Post-op respiratory failure is very common in these patients, so respiratory exercises should be given. And finally, venous thrombotic episodes. The other one, Cohen's syndrome, in pre-op status, their potassium and should be taken. You should begin spironolactone in them, as I already show one more the reference to this thing. And intraoperatively, you should avoid hyperventilation because they are in alkalotic state. There should be strict hemodynamic control, potassium level, and gas analysis should be done frequently. This is the last guideline which I'm going to present for glucocorticoid medication based on current evidence. So if the patient, this is the type of surgery, either it is superficial, minor, moderate, or major, and these are the recommended doses which should be given. This is the most latest evidence, and this is just published in 2021. What it is saying that in minor surgeries, a usual daily dose is sufficient. In moderate surgery, it should be 50 mg before incision and 25 mg 8 hourly till 24 hours. And in major surgery, 100 mg before incision and either 50 mg 8 hourly for 24 hours. Okay, and now this is the management of adrenal crisis, which we actually gone through very detail. And this is also some more details about the doses which you should do in pre-op, intra-op, and post-op management of patient who present to you with Addisonian disease with adrenal insufficiency. So you can all have a look on it, what we need to have in pre-op and intra-op, post-op period. So this is all. Actually, I have to cover 4 topics, so they were really huge because the disease is very big whenever it comes to adrenal gland. So I think we have only got 5 to 6 minutes more, which we will take for the questions. Thank you. I hope I was very clear in all my points.
Thank you very much, Dr. Anum. It was really very well researched and very well presented topic. And now I would invite participants to ask questions if they have any. Hello.
Yes.
Dr. Anum, I have a question for you.
Yes.
Have you ever considered this post-COVID adrenal insufficiency, or have you come across any patient who was post-COVID and had adrenal insufficiency?
Well, I think this is a very good question. It actually didn't click in my mind, but usually in post-COVID patient, we have those patients we had in our ICU. So as I have shown in my slide, that such patients also have adrenal insufficiency and they need cortisol supplementation. But yes, I need to really check if they
there have been
respond
many
into
cases
adrenal insufficiency.
which have been reported, after COVID. Actually, post-COVID
Yes.
syndrome is very, very well researched topic, and there are many cases which have been reported in the literature, after COVID. So since it has been 3 years from now, and we are coming across post-COVID patients in our preoperative clinics.
Yes.
So we have to be careful, I think, in taking history as far as COVID patients are concerned.
So this is also a very important point that sir has added, that if there is also a history of COVID, then one should once again think in their mind that they might be having adrenal insufficiency as well. And yes, the literature
some symptoms are
just
there.
going through it also.
Yes. Any other question from participants, please? I don't think.
So even on the
it was so
internet,
well
there are
researched,
few case
very
reports.
well presented topic that everybody is very clear in their mind.
Thank you, sir. So yes, I try to give the best of me, and at least after this 1 hour lecture, the participants should have a basic knowledge of it.
Really hats off to you. I mean, it was very well presented. And but I just wanted to, I would like to tell you that if you improve your time management, in presenting any paper or any, presentation. So
yes,
that
sir.
might
True.
improve.
Actually, the slides actually got so much when I started adding up on the recent guidelines, and there were so many things to further add on. But I just limited myself to 51 slides. But it should be improved, inshallah, sir. Next time, inshallah.
Okay. Now I think we can conclude this session. And I will thank.
I'm Assalamu alaikum. I'm Dr. Zishan. I will just add to what Dr. Shabir just mentioned regarding time management. And I will just add on one thing that at the end of the day, actually being an anesthetist, we are more concerned about the clinical aspects. Okay. So clinical aspects need to be highlighted to the residents, because sometimes they are overdoing the basic sciences. Okay, and when they are doing overdoing basic sciences, they miss the business end, which is the clinical part. So
Yes, I totally
that's
agree
what.
with you. I totally agree with you. If you concise, these basic sciences, in our
because
lecture,
because Dr.
could you
Shabir, I
just
will sorry to one more point, that actually practically speaking, what will happen, that these patients who are on steroids, sometimes they are not necessarily on prednisolone, they are on some other steroids as well, maybe. Okay, so you should just need to, as a clinician, you will be needing 2 3 more important things, that what sort of surgery it is, what sort of stress it is, and how you should replace it, whether with only a induction dose or you have to continue it, and then you have to endorse it to the surgeons, because this will be your responsibility to make sure that the stress dose of the steroids has been administered.
very true.
This will be one
I
point,
totally agree
and
with you. Totally agree with you.
yes, and the other point will be that you should be just expecting the clinical part. Like, for example, these patients may be morbidly obese who are on steroids. These patients may have fragile bones, so they need to be taken care of with that thing. Their skin will be very fragile, so IV lines need to be taken with care. So these are like more of the clinical aspects you should be taking care when you are dealing with such patients. So that's
I
what I
think
just
Dr.
wanted
Anam
to
has
add.
already mentioned these things. I'm sure Dr. Anam has already mentioned these things, this osteoporosis and
No, no, no.
uh,
She has mentioned. I'm just saying that the business end should be
yes,
highlighted. Just
yes,
like, when we
I
are
agree with you.
presenting any food to anyone with the garnishing, the
Yes,
garnishing will be more pronounced.
yes,
So at the
I
end of
agree
the
with
day,
you.
the business
I,
end should be highlighted more. Anyways, thanks a lot, Anam.
thank you. Thank you very much, Dr. Anam. Thank you very, very much. And thanks to all the participants and the organizers, especially Dr. Komal Zafar and Tahir and everyone. So we conclude this session and call it a day. Have a good day. Have a good day.
Thank you.
Thank
I think there's still some problem with the connection at Dr. Sanam end. Thank you so much, sir. I think we shall end this session today. All the participants, please fill in the feedback form we have sent in the chat box.